Welcome to our next session of ETAT. Today we'll be doing Module 4, Coma and Convulsion. In this module, we look at the second and third components of the letter C. We have ABC, airway, breathing, circulation, and then another two C's and then a G. This two C's stand for Coma and Convulsions. The following signs indicate that there is impaired neurological status: coma, lethargy, and convulsions. And on the right-hand side, we can see where it fits in. At the end of the module, our objectives are that we should be able to assess the level of consciousness, manage coma and convulsions, identify and manage hypoglycemia, know how to determine the doses and volumes, how to draw up and how to administer anticonvulsants. We also will need to have a plan for dealing with ongoing convulsions. We can see now that coma and convulsions are covered in charts 6A and 6B. On the left-hand side, we will diagnose coma when P or U on the AVPU scale, which we'll get to just now, are present, or currently convulsion. Then, if either of these ones are present, it is an emergency sign. We immediately take the child to the resuscitation area, manage the airway, position the child, check the glucose, abort the seizure. Very important to remember that if there's any suspicion of neck trauma, we will stabilize the neck and not put the child in recovery position. Chart 6A has got an algorithm for managing convulsions, which we look for further in detail. It covers 4 steps. Chart 6B on page 85 is very important because it contains the volumes and doses for our anticonvulsants. We are covering lorazepam, midazolam, and diazepam. On page 86, we have other drugs: phenobarbital, phenytoin, and sodium valproate, with the exact instructions with how much to give for which dose and safety issues to look out for. On chart 7, which is also very important, page 87, we have advice on how to administer glucose. We'll be covering it in more detail later on. If we assess the child for coma and convulsion, we need to know one of two things. Is your child in coma, and is your child convulsing now? It can be very obvious sometimes that the child is playing and talking, obviously does not have a problem with this level of consciousness. To review again, if a child is coma or convulsions, we will immediately go to the emergency area, manage the airway, position the child, look out for neck trauma, check the blood sugar, give IV glucose if needed, and abort the seizure. Our first line will always be a benzodiazepine. So how do we know whether a child is in coma? The Glasgow Coma scale is not very suitable for children in this situation. That's why we use the AVPU scale, which is much easier to use. A is the child alert. V is the child responding to voice. If it doesn't respond to voice, does the child respond to pain? If it does not respond to pain or voice, we will say the child is unresponsive, and that means he'll be in coma. You can see on the right-hand side, a child with A is alert, responds to voice is lethargic, responds to pain is unconscious, and an unconscious child is in coma. Is the child in coma? If we find the child is not in coma, we go on to the next assessment. If the child is not alert, we do exclude sleeping. We're asking the caregiver to try and wake the child by gently shaking and calling the child's name. If the child does not respond, assess for response to pain by squeezing the nail bed hard enough to cause pain. We'll be looking at some videos later to demonstrate this. To repeat again, is the child in coma? We'll be using the AVPU score. If it's P or U, in other words, does the child respond only to pain or is unresponsive, it will be in coma, and this is an emergency sign that we need to take to the resuscitation area and manage urgently. Now we come to the second C, convulsions. We want to know, is the child convulsing now? So Convulsions are usually associated with a sudden loss of consciousness, with uncontrolled jerky movements of the limbs or the face, stiffening of the arms and legs, uncontrolled movement of the limbs. There might be loss of control of the bladder and unconsciousness. In infants, small babies, the jerky movements may be absent, but there may be twitching, abnormal facial movements, and abnormal movements of the eyes, hand, or feet, which are also seizures and also need to be managed. You might have to observe the infant very carefully for these signs, and we'll show you some videos later on. So remember, we want to know, is the child having a convulsion now? Not, does the history of convulsions. If the child had a convulsion before and is alert now, then you can be assessed otherwise. If there's a convulsion, it's an emergency that needs to be attended to quickly, take the child to the resuscitation area and manage the convulsion. So you can see here's a table with the management of coma and convulsions next to each other, because they overlap and very similar. With coma, if the child is unconscious, you will manage the airway, position the child, always remembering to think about trauma, attempt an intravenous or intraosseous line to take some blood, check the blood sugar, give glucose as needed. You can see it's very similar with convulsions. Manage the airway, position the child, attempt an IV or intraosseous line, check blood sugar, give glucose if needed. Very important, stop the convulsions. If the temperature is more than 38.5 degrees Celsius, give paracetamol. Firstly, managing the airway. You will manage the airway as you have learned in Module 2. Prevent aspiration and protect the cervical spine. If it's needed, you can use an oropharyngeal airway, and we will give oxygen enough to correct hypoxia if the oxygen saturation is less than 90%. Just always remember, if neck trauma is suspected, stabilize the neck and open the airway without moving the neck. This is the jaw thrust procedure. If no neck trauma is suspected, you can open the airway using the neutral or chin-up position, depending on the age of the child. In convulsions, very important to remember, we do not want to insert anything in the mouth to give it open, even an oropharyngeal airway. If the lips and tongue are not blue, do not try to manage the airway by lifting the chin or using a jaw thrust. Allow the child to breathe. If hypoxia is present, we give oxygen. And remember, we give just enough oxygen to correct this hypoxia. Too much oxygen could also be harmful and is not helpful. So how do we position the child in coma? If there's no suspicion of neck trauma, we can keep the airway open and place the child in this recovery position as we see on the right-hand side. So turn the child on the side to reduce the risk of aspiration. Keep the neck slightly extended and stabilize by placing the cheek on one hand. Bend one leg to stabilize the body position, as we can see in figure 25. For convulsions, as we said again, do not attempt to hold the child down or put anything in the mouth. If a child does vomit, turn the child on his or her side to avoid aspiration, always remembering to think about neck trauma, in which case you need to stabilize the neck. If the convulsion has stopped and the airway is clear and there is no history of trauma, the child can be placed in the recovery position, as we saw just before. Now we want to take some blood. This will be demonstrated in detail when we do the face-to-face session. We also want to use this opportunity to check blood sugar. Hypoglycemia is a very important treatable factor. So if the glucose is below 3, we are going to diagnose hypoglycemia. Just remember that if a child is unconscious or convulsing, and for some reason you cannot do glucose testing, you should assume that the child has hypoglycemia and rather give intravenous glucose as treatment, as it is less harmful than missing hypoglycemia. Remember, after the ABC, we have the DEFG. Don't ever forget glucose. So how do we give glucose if needed for coma and convulsions? We said we're going to diagnose it if the sugar is less than 3. We're going to give 5 milliliters per kilogram of a 10% glucose solution rapidly by IV injection. We are not going to give the 50% dextrose like they often do for adults, because it's very hypertonic and can cause problems in the veins. Followed by infusion of maintenance fluids containing 5 to 10% glucose, for example, like half TD. On table 4, page 33, you can see the dose exactly. So in table 6a, you can see the first intravenous or intraosseous dose. We will be giving 5 ml per kilogram of 10% dextrose. Then when we repeat the sugar and it's still low, we will give a smaller dose of 2 milliliters per kilogram of the same solution. If we can't have IV access, we might give milk or sugar solution by nasogastric tube. In a real emergency when we can't do anything else, we will give the undiluted 50% dextrose 1 milliliter squirted into the mouth. So our first problem is that we don't often have access to a 10% glucose solution. So we will have to make it from a 50% dextrose or 50% glucose solution impure. And it's very important to get this right. To make a 10% glucose solution, you must dilute 1 part of 50% glucose solution to 4 parts of sterile water. And maybe the most easiest way to remember it is to use a 20 ml syringe, draw up 4 milliliters of 50% glucose solution, and then fill up to 20 cc with 16 milliliters of sterile water. 4 and 6. To help you, there's a table 6b, which will tell you how many syringes you need for each weight and age category. So for example, a child that's weighing between 14 and 19 kilograms will need 80 ml. For that child, we'll need to prepare 4 milliliters, 4 syringes of 20 milliliter. So the next step, after we've given the blood sugar treatment, we will recheck the blood glucose in 20 minutes. If it's still low, like we said before, we're going to repeat a lower dose of 2 milliliters per kilogram of 10% glucose solution. As soon as the child is conscious, we will be feeding the child. If no intravenous or intraosseous line is available, we can give 5 milliliters per kilogram of milk or sugar solution by nasogastric tube. To make the sugar solution, we will use 4 level teaspoons of sugar or 20 grams and 200 milliliters of clean water. If no other options available, we can give 1 milliliter only of 50% dextrose buccally in the space between the cheek and the lower gum. But don't ever forget glucose. So in a child having convulsion, the blood sugar can be checked immediately or after the first dose of an anticonvulsant has been given. In ETAT, we teach you to work as a team together. So while one person is attending to the convulsion, another one can actually do the blood sugar at the same time if there is enough staff available. Chart 6a, like we said before, it has a summary of how we manage convulsions and what is the next step if our treatment did not work. In more detail, the first thing you need to know is the intravenous access. If there is, you can use any of lorazepam, midazolam, or diazepam intravenously. If you do not have IV access, you can use lorazepam or midazolam buccally. Diazepam cannot be given buccally, or IMI can only be given rectally. We can choose any of these 3 drugs which is available. It's very difficult to remember the doses of these drugs. That's why our charts are very helpful. If the child is still convulsing after 10 minutes, and hopefully in that time we are inserting an intravenous or intraosseous line, we will repeat another dose of the same medication that we've given before. Those are the first 2 steps. Some words about the anticonvulsant. Lorazepam is a small volume which is ideal for intramuscular injections and for buccal use. It has the same dose for intravenous and buccal use, but it needs to be refrigerated, so it's usually not available at primary health care. Midazolam is suitable for all routes, but is available in two different concentrations, 1 mg per milliliter in a 5 milliliter ampule and 5 mg per milliliter in a 3 milliliter ampule. And the doses are also different for IV and IMI or buccal, which you should pay attention to. Diazepam should not be given IMI, but can be given rectally. Just to reinforce again, you need to pay attention to the different doses of different routes of administration, especially for midazolam and diazepam. Note the concentration of diazepam or midazolam used. Is it 1 mg per milliliter or 5 mg per milliliter? Check the dosage chart 6b before giving the medication. It's very important, if possible, to use the actual weight, but don't delay treatment to weigh the child. We can estimate the weight using Brosolo tape or Pauper tape, which is more accurate, or we can estimate it by using a weight formula age plus 4 times 2. On chart 6b, we will see lorazepam, midazolam, and diazepam doses. For each weight band, midazolam has got two different ones for IV and then buccal or IMI for the different strengths. Diazepam has got a rectal or IV. Just remember, pay attention to what strength you are using and what route you are giving it by. Also very important to remember that in children under 28 days of age and neonates, we prefer to use phenobarbital to control their convulsions. If IV access is not available, we can give buccal, that means on the inside of your cheek, midazolam or lorazepam. We draw out the dose from the ampule into a tuberculin syringe. It's very important to use a syringe with a detachable needle so that we don't injure the child. 1 milliliter syringes are very useful because we can accurately give these small doses. Then we remove the needle, place the child in recovery position, insert the syringe into the side of the mouth between the gum and inner cheek and inject the solution, which will then be absorbed. The dosage charts are chart 6b, and we can give lorazepam or midazolam this way. Very important again, try to get the weight of the child to work out the correct dose. If IV access is not available and we would rather give rectal diazepam, we also draw it up into a tuberculin syringe, remove the needle, place the child in the recovery position, apply lubricant to the syringe, insert the syringe into the rectum for 4 to 5 centimeters and inject the diazepam. Hold the buttocks together for a few minutes. The dosage charged for diazepam are on chart 6b. And also important to remember, use the weight of the child whenever possible. If intravenous or intraosseous access is not available, it should be established as soon as possible. Intravenous or intraosseous anticonvulsants can be given directly into the vein or intraosseous needle slowly over at least 4 minutes. Remember, giving too much of these drugs will typically may cause respiratory depression. That's why it's very important to reassess the child's breathing regularly and make sure you have a correct sized ambu bag and mask on hand when you give anticonvulsants. Then we'll reassess the child after 10 minutes. If he's still convulsing, we'll give a second dose of the same drug that was given initially, preferably intravenous or intraosseous. Then we have the next line. If we've already given 2 doses of benzodiazepines, then we get to medicines which are potentially dangerous. So the first question is cardiac monitoring available? If it is, then we can give phenytoin, 20 mg per kilogram slowly IV over 20 minutes. It's very important to mix it in normal saline only, not in dextrose, and also to monitor the ECG all the time as it can cause arrhythmias. If after you've given a phenytoin the child is still convulsing, then you can give 20 mg per kilogram crushed phenobarbital tablets. If we do not have cardiac monitoring available, we will go straight to phenobarbital 20 mg per kilogram via nasogastric tube. If after 10 minutes the child is still convulsing, we will then give phenobarbital 10 mg per kilogram. It's important to remember that the second dose of phenobarbital is half the initial dose. This is to recap what we said before. We can either use phenobarbital or phenytoin, but a high level of monitoring is required because of potential side effects. Phenobarbital is preferred for smaller children. Phenobarbital can give respiratory depression, and phenytoin can give arrhythmias. And here we have the dosages, 20 milligram per kilogram. We can either use the syrup or the tablet, depending on the size of the child. If the child is still convulsing, remember second dose, 10 milligram per kilogram, which is half the dose we gave before. Or we can use intravenous phenytoin if we can manage the child ECG. Reinforced again, if cardiac monitoring is available. We're not allowed to mix it with a dextrose-containing solution. So the dose, the dilution, and rate of administration are all very important. So while we are giving it, we should monitor the child for abnormal pulse, arrhythmias, and hypertension. We should stop the infusion if any abnormalities are detected. Once a child is stable, infusion can be restarted at a slower rate, for example over 1 hour. Only one dose of phenytoin should be given and is not to be repeated. If phenytoin was used as first line and the child is still convulsing, then you can give a full dose of phenobarbital 20 milligram per kilogram. Step 4. And this can happen at any stage during the referral process, management process. Discuss with senior referral center regarding further management. The child might need intubation and transfer. Recheck the glucose and consider antibiotics, especially a child that's unconscious and convulsion might be due to meningitis. On a regional level of care, one can consider intravenous valproate, which should not be used in an infant, small infant, or of liver disease or error of metabolism is suspected. We'll be looking at some videos now. Here we can see that the child is not very interested in what's happening around him. We're looking at lethargic. You can see this child doesn't respond at all, even to noise. Or to having his arm shaking, woken up a little bit. So there's some reaction there. So he's not in a coma.
Fast asleep.
You can see it looks like this child is very unresponsive. The children also sleep sometimes. You can see she's woken up quite a bit now. Here we have another very sick child. Even though the eyes are open, you can see the child is not really responding in contact with the environment. does not respond to noise or being shaken. See, the eyes are open, but he's not in contact with reality. You can see when the finger is being pricked what happens. Does not pull away, does not localize the pain. You can see this one, when you hurt him, he pulls his arm away, so he's reacting to pain. You can see a generalized tonic-clonic convulsion. Body shaking, arms and legs, face and head. Yeah, you can see just the face, head is moving. And you can see some chewing movements, which is also a seizure. Also needs treatment urgently.
A drop of blood is placed on the yellow part of the stick, and the result is read within a minute.
Okay.
This child is hypoglycemic and needs urgent treatment with glucose. Hypoglycemia is common in children with coma or convulsions. If the blood glucose cannot be measured, glucose should be given.
See, it's 1.8, so it was low. It needs treatment. You need to be comfortable with the type of machine you use at your facility, which are a bit different from these older types. Some other aspects that we need to pay attention to. If the child's got a very high temperature, we should treat the temperature with rectal paracetamol is the best route if it is available. So paracetamol we give 15 mg per kilogram per dose 6 hourly, orally, per nasogastric tube, rectally, or even IV if it is available. Now, what investigation should be checked with children with seizures? DEFG, remember, we should have checked the sugar. Then electrolytes, UNE, and calcium, magnesium, and phosphate. We should consider doing a lumbar puncture if the following are present. Fever with signs of meningitis, that includes irritability, bulging fontanelle, neck stiffness, positive Koenigs or Brzezinski sign, headache and photophobia. Fever and altered consciousness or seizure with the following. Less than 18 months, especially less than 6 months. Complex febrile seizures. Antibiotics given before assessment. If a child was not vaccinated against Haemophilus or strep pneumonia, we don't know the vaccination status, then we should be very suspicious and do a lumbar puncture to exclude meningitis, as we can treat it then before damage happens. It's important to remember that there are certain situations in which an LP should not be performed because it could be dangerous. Number one, coma, a POU and FPU. any focal neurological signs, any weakness, cranial nerve abnormalities, signs of brainstem herniation, signs of raised intracranial pressure, sign of respiratory compromise, sign of shock, infection of the skin overlying the site where you want to put a needle in, and evidence of a bleeding disorder like THA or any bleeding. Consider cranial ultrasound or CT scan before you do an LP if there's altered consciousness or a new focal neurological deficit. Now we're just in summary. If the child is unconscious, you should manage the airway, position the child, remember to stabilize the neck if there's history of trauma, put in an intravenous or intraosseous line, take bloods, check the blood sugar, give glucose if needed. For convulsions, very similar, manage the airway, position the child, take bloods, check blood sugar, give glucose if needed, stop the convulsion. Like we said before, the glucose giving and the convulsion stopping can happen quite near to each other, but they should not be forgotten. If the temperature is more than 38.5 degrees, you can give paracetamol. If the child doesn't have shock and is not unconscious or convulsing, we will continue the assessment for emergency signs. If the child is unconscious or convulsing, you should initiate appropriate treatment and then quickly resume the assessment. The questions for this module you will find on page 48 and 49 in the manual. Thank you very much.